Welcome to Focus on Your Health, your radio home for news and stories from Kingman Regional Medical Center, here on the KJAZ Radio Network. I'm TG LaFredo, and this week I'm at Mohave Pain Management and Rehabilitation, speaking with Dr. Sarah Knievel. Hi, Dr. Knievel.
Hello.
Welcome. Thanks for being here.
Thank you for having me. This is a great opportunity.
Cool. Well, I've been trying to get in touch with you. You're super busy. It's not that easy to get to you.
It is. I'm very busy, but I also work part-time, so that makes it more difficult.
Good for you, though.
I like it.
I apologize in advance for starting here, but Knievel's not a very common last name.
Yeah. Well, you're the first person that's asked me that today, which is unusual. Usually somebody brings that up. It's my father's third cousin, twice removed. Evel Knievel was.
Evel Knievel. Mm-hmm. See, I just had a feeling, for one, again, it's not a very common last name, but then I thought, well, let's see, I did a little bit of research, and according to the Guinness Book of World Records, by 1975, Evel Knievel had suffered 433 bone fractures.
Yep, Guinness Book of World Records for fractures.
And here you are in pain medicine.
I know.
It just makes sense.
Well, actually, I probably should have been an orthopedic surgeon, but I'm not really into power tools, so that's how I ended up in pain management.
And I came in, and there's an Evel Knievel bobblehead in the office, and I thought, okay, I'm probably onto something.
Yep.
But still, even if you weren't related.
Unfortunately for the listeners in this general area, I don't ride motorcycle.
No, that was my next question. Then I was wondering if Uncle Evel ever came to Thanksgiving dinner.
No. In fact, he was pretty by himself. My sister, whose name is Knievel too, we were living in Colorado, and she went up to a jump that his son, Robbie Knievel, was having at Estes Park. She went up, she showed him my ID, said, "Hey, can I meet Robbie?" And they said no problem, and they let her in, and she got to meet him. He was really, really nice.
Yeah.
So
you want to take her
closest.
for a ride, though?
No, I don't think she would have done that.
I was picturing this whole scenario where, you know, your mother's crying, and she's like, "Why can't we just have a normal holiday like everybody else?" You know, and
we can still manage that without the Knievels being at our events. But,
okay.
But there's not as much accidents occurring with motorcycles, so we don't suffer from that.
Okay. So you mentioned Colorado. Is that where you grew up?
No, I grew up in Minneapolis.
Minneapolis.
Suburb just south of it.
Okay. And I know that you went to med school in Colorado.
Yes.
Is that right? University
Undergrad and med school, University of Colorado.
And you lived in Denver at that point.
Mm-hmm.
How was Denver for you?
Oh, I love Denver.
Yeah.
Great city.
I do too.
Very fun to live there.
I had a lot of fun there. I just stayed for a summer or something like that, but Denver was...
It's a good city because the access to the outdoors is great. It's a bad city because it's busy and there's a lot of people there, and it's not the greatest place to practice medicine. At least that's what my husband and I decided when we left our fellowship and our residency.
Oh, air traffic.
See, if James was here, he'd be like, helicopter.
I know, I'm like that about
helicopters. It's just flight for life. Don't worry about it.
Yeah. Could it be that important? We're trying to record
Excuse
a show
me.
here. I want to ask you about your son, James. You told me about an interesting revelation that he had the other day. He was talking to you about trucks.
Yes. Let's talk about trucks.
Uh-huh.
And he noticed that trucks don't traditionally have wings, and there's often dump trucks, and they're good.
This is very wise of your son.
He's very, very ahead of his game for a 3-year-old.
I think if you start writing down those musings,
I know.
you will have the best greeting cards, the best fortune cookie material that's ever been.
I should record that stuff more.
Consider that. Get some microphones.
That's a good idea.
Because soon he's going to start talking like the rest of us, and all the fun will be gone.
That's true. And then he'll probably stop talking to me because he's a boy. So
He'll just be busy brooding and
I know.
working with machines
Do
or
you
something.
remember when you used to tell me, let's talk?
Do you remember when you loved me?
Yeah, I know. Hugs.
Okay, so let's get on with business, shall we?
Okay.
You've been here since 2012, is that right?
Yes, September.
What brings a person particularly into pain management, this branch of medicine?
So I did my residency in physical medicine and rehabilitation, just like Dr. No. Mm-hmm. And physical medicine rehabilitation is all about function for people recovering from strokes, spinal cord injuries, sports injuries, The goal is to return people to their previous level of functioning.
Right.
I really enjoyed it, but I also really enjoyed an element of pain management because I felt like the opportunity to really help someone who is in pain can be extremely rewarding and actually very fun. Learning about pain management in an isolated university setting is interesting because it's very different than the type of medicine that's practiced in small town United States, which is basically the majority of this country.
Okay.
And so when I went into pain management, I did it because I enjoyed the procedures and I enjoyed the idea of helping somebody who could recover from an injury and return to a previous level of functioning. But the reality is when you're in small town America, which I didn't necessarily understand until I left Mayo, the practice of pain management is very different. And I find myself doing less procedures and more education regarding the treatment and etiology or causes for pain. And so initially it was a difficult transition for us. My first job was outside of Charlottesville. It wasn't in Kingman. And the town that we lived and worked in was very similar in size to Kingman. And so I didn't necessarily understand what I was getting into. And after about 6 months of working there, I understood that this was going to be a lot harder than I thought it was going to be, but I think my chance to do good in an environment like this is much greater than if I were to be in an environment like Mayo or a university setting. So being in Kingman, I feel like I really can actually help a lot of people more than I would somewhere else that it would be easier for me to practice in. But there's a lot of uphill battles with pain management.
I wonder about these uphill battles with pain management because I'm kind of a sissy when it comes to drugs. And
That's fine. You know.
Years ago, I had to have my wisdom teeth out, and I put that off as long as I could because I didn't want to be put under for that. I'm just maybe it's kind of a control freak thing. I'm not comfortable around drugs or intoxicants, and then I think probably a lot of us are like one good car crash away from having a potential encounter with some serious narcotics.
Well, so medicines affect everybody differently.
Yeah.
And so when people are prescribed narcotics, even between families, one person may have a significant reaction to it. Another person may become very ill. They may not work for some people. But unfortunately, the truth is that narcotics are very addictive substances. And that is why the FDA has classified them into a category that requires further monitoring from the providers and the FDA themselves and your pharmacies. So, you know, it's people who get addicted to pain medicines traditionally have a history of addiction.
Okay.
And it's not something that just comes out of the blue. But addiction is a very, very complicated process that involves more than just pain. There's a lot of family history that goes into it, home life. And all of these are elements that I try to ascertain or understand about patients before I enter a relationship with controlled substances, because I do not want to put them in a situation where if they are significantly predisposed to addiction, I don't want to give them the opportunity to become addicted to something else. It's like giving a recovering alcoholic a drink. You just don't want to do that to someone.
Now, if it's someone who's dealing with some significant pain, what other treatment options do you have if it's someone who has a lot of those warning signs?
Well, there are a lot of other things you can do. There's other medications that are not as addictive. They're non-opioid treatments. A lot of them are neuropathic pain medicines. Lots of times even over-the-counter analgesics aren't used appropriately. Procedure-wise, there are many different procedures that you can do that can help subacute chronic pain, and they can be very successful. Surgery is definitely also an option in some circumstances. That's not something I practice, but I do refer to surgeons at times. And I don't want to scare people about using opioids. They're not bad drugs. They just have to be used responsibly. And I think that's the trouble that has occurred in the United States today. More people die from narcotic overdose in combination with other substances than they do from motor vehicle accidents now.
Wow.
It's the CDC states that opioid and other controlled substances is the number one cause of accidental death, which is tragic because 20, 30 years ago, these medications weren't prescribed at all unless you were a cancer patient and dying. But so I think the irresponsible nature in which these medications has been prescribed has resulted in a lot of bad things for our country. and people dying because of it.
We were just saying you've been here for about 2 years now. Based on what you've seen, what is the scope of the problem with people misusing prescription drugs?
So Mohave County is 6th in the nation for abuse of controlled substances for people over the age of 12. 1 in 4 high schoolers and perhaps middle schoolers, I'm sorry if I don't remember it specifically, have tried a narcotic from their parents or family friend drug cabinet. And the reality of young people's impression of narcotics is that, well, it's in my mom's cabinet, so it must be safer than liquor. So a lot of people are starting to use narcotics more recreationally because the availability is that much more great than it was, 20 years ago. So there's been some changes that have occurred, mostly things that have been recommended by the government and the FDA, that has made it more difficult to freely dispense opioids, like, say, that was happening maybe 3 or 4 years ago in Mohave County. But there still is a huge problem. And northern Arizona, New Mexico, parts of Nevada, Utah were probably some of the worst parts in the country.
Time for a quick break on Focus on Your Health. We'll be back with the second half of my conversation with Dr. Sarah Knievel. This is the K-Jazz Radio Network. And welcome back to Focus on Your Health, here on the K-Jazz Radio Network. This week I'm at Mohave Pain Management and Rehabilitation, and I'm speaking with Dr. Sarah Knievel, who is busy. When I got here, I found her working through lunch. She was catching up on dictation while eating a salad.
MRI evidence of severe cervical stenosis proximal to her fusion. Discussed surgical referral. Patient is hesitant given the fact there are no local neurosurgeons, period. Physical exam is not consistent with myelopathy, but is likely a contributing factor to her neck pain.
There was a physician a couple of years ago, I think, in Mohave County who got into some trouble he just sort of had a dispensary, I think, right?
Yeah, and I don't know too much about it. I haven't spoken with a lot of people in the medical community about it. Actually, right. I've learned more from reading the local newspaper.
Okay.
But my understanding was that and this is part of the problem, I think, that there was a large pendulum swing in the way that narcotics were prescribed starting about 15, 20 years ago. Before then, like we discussed earlier, people only got narcotics when it was in a cancer or a malignant setting, and we didn't really understand the long-term effects of narcotics at that time because, a lot of those people died. But there was a large push from the pharmaceutical industry for financial reasons to promote certain medicines that changed the prescribing pattern of people in the United States. And around that time, too, it was discovered that it could be very profitable to have what was called pill mills. People seeing 50, 60, 70, 100 patients a day.
Wow.
And just prescribing medications.
Like 60 seconds at a time, essentially.
Pretty much, as long as it would take for me to write out what you were getting in my signature, perhaps. Which really is totally counterintuitive to everything that we just spoke about.
Yeah.
How do you avoid running into trouble with substance abuse or side effects from narcotics? And I know that there was a gentleman who was practicing like that, and he did get in trouble for Medicare fraud because he was billing so high. He was billing at levels that he technically couldn't have ever really done in a 24-hour day period.
Okay.
Now, I do prescribe opioids regularly. It is a large portion of my practice, and I think that if they're managed responsibly and patients can tolerate them without a lot of side effects. I mean, they are a treatment option for chronic pain. I don't want to make it seem like I'm not, for prescribing narcotics, because the reality of my practice is that we do prescribe a lot of pain medicines.
Right.
But it's a very fine line how it's done appropriately.
Yeah.
And obviously that man who is no longer in our country, he was not doing it correctly.
Yeah.
So.
I had a feeling, I didn't really know the details of that story, but I had a feeling it was something like that. I don't want to beat this topic to death, but I do want to ask you one other thing. I found this AP story from October of last year. And it begins like this. Los Angeles, the doctor convicted of killing Michael Jackson was released from jail Monday after serving nearly 2 years of a 4-year sentence. So then he was serving as Jackson's personal physician, and he was giving him
Propofol.
Thank you.
Unmonitored. Propofol is a medicine that is traditionally used by anesthesiologists in an OR setting, which is one of the most controlled environments that we can create.
Sure. Yeah.
And the thought of using propofol in someone's bedroom without, significant cardiac or any other type of monitoring is damn near crazy. So it's surprising that he lived as long as he did on that type of treatment, because, it's just, like we said earlier, that's just outside of the scope of practice of what he should have been doing.
All right. So what was he thinking?
I think he wasn't. I think he was genuinely trying to help. I do feel that 95% of physicians who go to medical school aren't doing it because they want to mess people up.
I'm sure.
This is a lot of work to try and screw something up. I think he was really trying to do the right thing, but he probably got so wrapped up in the current circumstances that he really lost sight of what was going on. And just, obviously there's no checks and balances for a provider practicing medicine in someone's home. I mean, working in a hospital or a larger institution, there are, regulatory recommendations and other things that try to keep us in line. And I think he kind of lost sight of what his responsible treatment was there.
Yeah, I kind of think if you're not going to do this service for us, there's another doctor who will. We're the Jacksons. I don't know. Maybe not. Maybe I'm...
Quite possibly so.
Maybe I'm wrong.
It may have been a huge financial incentive for him, which is horrible to say, but that may have been a huge proponent of it too.
It didn't work out so well for anybody then, if that's the case.
Not at all.
All right, this is kind of dark subject matter. Let's talk about some of these other therapies. I'm not sure if that would be the right term. Some of the other approaches to pain management that you use.
Sure. Like we talked earlier, I am a huge proponent for return to function, and a lot of people who have chronic pain often diminish their functional level significantly because they're scared of having pain. So frequently I need to reintroduce activity levels in a gentle, controlled manner that doesn't cause further injury or increase their pain further. That is frequently accomplished with physical therapy. Sometimes patients have too much pain to start with physical therapy, or they've tried it before and it was too painful. So I use a lot of injections to help with that beginning pain so that they can regain proper movements. For example, when people have low back pain, oftentimes their abdominal muscles don't work, and that's the natural feedback loop that occurs in our brains. It's not correct, but it just seems to happen. And so if your abdominal muscles don't support your spine, you're predisposed to further pain and injury if you're not, protecting your core. But if someone has too much pain to participate in physical therapy, trying some procedures such as an epidural or facet injections, which are small joints in your back, can be very efficacious to allow you to kind of restart moving the correct patterns that will really help you long term. Other procedures that we talked about before, radiofrequency denervation is a procedure that essentially deadens small nerves in your back that provide sensation to these joints. They're called facet joints. And a lot of lumbar spine pain is actually from facet joint arthritis. And some patients can do extremely well with that procedure. Pretty much everything I do is very minimally invasive. So either it works or it doesn't, but the amount of downtime associated with it is nothing like a surgery.
Tell me about spinal cord stimulation.
Spinal cord stimulation is a very interesting, and it's not new. It's actually been around for quite some time, but it's a device that changes the signals of pain that come from wherever it is in your body as it ascends up your spinal cord. And it can be very efficacious for different types of nerve pain, sometimes low back pain. They are devices that are implanted like a pacemaker would be implanted for someone who has heart problems. The beauty about spinal cord stimulation is that you can try it, and if you don't like it, you don't have to have it implanted. So that really will allow you to see whether or not it would help you without undergoing the risk of having a surgery. A lot of the studies that have been coming out recently regarding chronic pain discuss, like I said before, movement patterns, but general overall deconditioning. And I obviously have not been practicing that long, but my general feeling and understanding with the health of the American public today is really related to our profound deconditioning.
Can you define deconditioning for us?
Well, so deconditioning traditionally describes, let's say someone is in the hospital for 2 or 3 months for a horrible medical problem. They have maybe a heart attack or maybe a horrible motor vehicle accident. When you ask someone who's been in a hospital bed to get up and walk, even perhaps, or try and do the normal things that we do every day, get ready, take a shower, there's no way they can. They're so out of shape. And that is considered deconditioning.
Okay.
But on a more general level, I see deconditioning in almost all of my patients because they traditionally have some type of chronic pain that inhibits them from doing exercise for sure, and even other simple activities such as gardening or bending, lifting, because it just hurts so much. And so basically, because of the pain, you inhibit all of the activities besides maybe standing and walking from couch to table, car, in the grocery store. If they're that deconditioned, they'll use a cart as opposed to actually pushing a shopping cart. And so after doing that for even a couple months, it's profound how deconditioned we become.
I can see this is going to be a vicious cycle.
It is.
You don't do it because it hurts, but then it hurts, so you don't do it, and then your mobility just diminishes,
continues
your flexibility.
to suffer more, and when your mobility decreases and your flexibility decreases, you're prone to further injury.
Right.
And you see exactly where this is going.
Sure.
So not only does pain happen in those circumstances, but then your diabetes disease processes and your heart disease things kick in because we're overweight at that point. It's a huge problem for the American public.
We had Dr. Mary Jurison when she visited.
She trained me at Mayo.
Oh, really?
Mm-hmm.
Yeah. She was lovely. We did an interview when she was here in town, and she was talking about prescribing, quote unquote, Tai Chi for her patients.
Yes.
Do you find yourself talking with patients about activities like that?
Exercise and diet all the time.
Right.
All the time. A significant proportion of people who have back pain are overweight, and that is a problem because extra weight on your back and your joints, that does hurt.
Right.
Almost routinely, I talk to people about diet and exercise, and I don't think the Americans' public perception of what diet and exercise really is fitting with what the general medical population and providers think it is. So there's a lot of misunderstanding, particularly with diet.
That's some part of why we're here.
Yeah.
We can't reach the whole public, but we're doing what we can. My wife tells me she'll talk to her patients about, so does he have a lot of fruits and vegetables in his diet?
Fruit snacks.
Well. Well, yeah, French fries.
Oh, wow.
That's not exactly what we had in mind.
Let's talk more about fruits and vegetables.
Call any vegetable, call it by name. Call any vegetable.
That's Dr. Sarah Knievel of Mohave Pain and Rehabilitation. You can reach her office at 928-681-8570. That's 681-8570.
All the vegetable will respond to you.
Dr. Knievel, thank you so much.
I appreciate the opportunity to be here. Thank you very much. This was fun.
And that's it. We're out of time. I'm T.G. LaFredo. Thanks for listening. Please join me again next Saturday at 11:30 a.m. for another edition of Focus on Your Health, right here on the K-Jazz Radio Network.
And the chances are good that a vegetable will respond.
Does he have real hands or are they fins?